Welcome, everyone. Thanks for being here. Thanks, Christine and Babu, for the invitation, and thanks for the kind introduction. So in this talk, I would like to describe a path the community has gone through in making mobile sensing a reality. I think we should congratulate ourselves in over the last 2 decades, maybe 1 decade for most things. We have been influencing the way in which sensors have been embedded in devices, the way in which systems are considering the energy efficiency of the sensors' data collection, and the way in which the data is interpreted to go into applications. So I think this community has been quite successful in this sense. In this talk, through examples of mine and other people's research, the good bit of being a keynote is that I can use other people's research and display it out there and talk about it. So I don't have to really be constrained by technical description of what we have done. And I will do exactly that. So here I really want to describe how we can take mobile sensing, and I think we are doing it as a community, to the next step, to be really the tool that allows us to do epidemiological study, large-scale behavioral study, and discuss the recent components that the community is working on to make this a reality. For this, I will go through a number of historical steps of my research and other people's research. So the first thing is a study we have done a few years back. This was around 2012, 2013. We put out a mobile app, and we expected about 50 participants to take up the app and use it. In reality, because it went on the BBC and then we were viral, and perhaps because the times were right, the app was picked up quite generously. And we had about 20K users and about 10K participants that contributed data. What was the app doing? Well, it would allow you to answer questionnaires and report your mood during the day, twice a day, really. But it would also passively sense through the variety of smartphones sensors that you're probably by now very familiar with. So here is just one picture of what this was doing and the results of the analysis that we had. Maybe I should put it on the other side, because I'm going to turn this way. I will do that now. And so this is just the display, sorry for the noise, of the accelerometer data of 150 participants throughout the weekdays. X-axis is time, and this is weekdays and weekends. This is divided by clusters. As you see, the top clusters are active people during the week. They're fairly active as well during the weekend. They just wake up later. But then during the day, they're very active. Second cluster is less active. Third cluster is really not very active. This activity is just accelerometer activity, like vibration level. So it's not really related to physical activity as such, which has been connected with mood in the past for quite a long time. So what this, and I won't show you the correlations, just trust me, there are papers on it, our papers that describe these correlations. These clusters were very correlated with different level of mood. So it looks like here there was a signal across population that shows if you are generally having a life, because you're carrying your phone, you're doing things with your phone, it was likely that your mood was better. So here's the holy grail. We have expensive sensing that requires you to answer questionnaires, describe your mood, that can be proxied, but much better, much cheaper sensors at large scale to give this sort of results. Now, since then, of course, other devices have been produced that have a variety of much better sensors, much wider sensors, and this is just an Apple Watch. And this is my heart data of the Apple Watch. So this is my heart for a period of a month. This is the heart rate is collected via, really for this audience, probably I'm saying something really obvious. It's a PPG sensor that uses light and reflection of light to measure your heart changes. And it also is able to do an echocardiogram sorry, not an echocardiogram, an electrocardiogram through the electrodes that are placed on the crown and around the case of the watch. This is done, it's one lead electrocardiogram, so it's really very much limited in terms of capabilities with respect to the ones you can do in a medical clinic, but it's something. You can follow your rhythm and can give some indication. We'll talk more about this. So, and now the issue is how do we go from the sensing to scalable and effective populational health studies? And my colleagues in the Medical Research Council Epidemiological Unit in Cambridge are very interested in this sort of use of wearable devices and use of proxies for health that are cheap and scalable and can be used, and the aspects of how do we interpret the data and make it really a reality. So one of the things, for example, we started looking into is what you have expensive sensors that can give you heart rate. The really accurate one thing I haven't said about the one of the watches, perhaps is less precise, both because of the positioning of the PPG sensor on a wrist, which is really the wrong positioning for heart rate detection, but also because of the type of sensor. So there are better sensors for heart rate that you can put on the chest, but actually wearing this on the chest is a bit more difficult, uncomfortable. And instead, we have accelerations that can be detected through devices that can be as cheap as $10 these days, in fact. So can the two be related to each other? Can we say something about heart rate just by using acceleration? These people in MRC epidemiology have, they don't fool around with studies. They really collect very useful data. This is a study of about 12,000 people on which they put wearables. 2,000 of them wore a wearable for a week. And they repeated the study at the distance of 5 years for the same users. So you have all of a sudden all the medical history and demographics, and they do, I'll explain in a little bit, they do even a little bit more on these people. And one thing that we started looking at with them is the correlations between heart rate and accelerations in this population. So we have both heart rate and acceleration here. And one thing that is clear is that actually, as you see from the picture, whenever your heart rate goes up, it means you're doing something often. And therefore, your acceleration also would indicate that. And one basic prediction forecast model already shows that with an error of 9 heartbeats per minute and some other metadata I'll say a little bit more later, you can have that more expensive data with the proxy accelerometer data. By using perhaps good modeling, so nowadays machine learning has evolved. We have better models that are able to deal with time series, that are able to deal with the dependencies of the data. We are able to go from acceleration to other demographics, other aspects of a user's life. So for example, by using a prediction technique that uses convolutional neural network, LSTM, GRU, and try to predict heart rate, we generate embeddings as an almost side effect of that process that are already inherently predictive of the characteristics of people's clusters. So we're able, with a certain accuracy, to predict gender, height, physical activity estimation, and expenditure estimation. I will talk about this in a couple of slides more, BMI and weight. So one of the key aspects of this prediction is the fact that the data somehow contains information that needs to be extracted using some novel framework and some novel methodology. So here we see the first convergence of trying to use sensor data in frameworks that are novel, even somehow for the machine learning community, because our data, our sensor data, is of a certain kind, has certain levels of sparsity, has problems and has advantages that need to be thought through when you put them into this sort of framework. I said I would talk more about fitness and energy expenditure a bit more. So if you talk to epidemiologists, they're really keen to understand your fitness level and how can we predict your fitness level just by simple, cheap sensing. Has any one of you ever done one of these fitness tests that measure your VO2max? Anyone? 1, 2 people. Are you athletes, guys? Are you? Yeah, so this is generally something that is done to measure your fitness and measure perhaps how you're training. And it's quite an expensive test. As you can see, you can do it on a bike or you can do it on a treadmill. It is something that costs money. So how do we scale this? How do we make this a more common test? Well, we're not the first one, and probably some of you have already thought of this. If you look into, if you have an Apple Watch or other kind of watches, the Apple uses a proxy of VO2max, which VO2max is simply the volume of oxygen that is absorbed into your body for generating energy. It's a sort of value that can give an indication of your fitness level. So to do the real test, you have to go on these machines, but there are proxies for it. And Apple uses a proxy that is really based on your activity, so it's based on your heart rate gotten in from the PPG sensors. And this is actually, by the way, my VO2max in the last year since I bought my watch, as you can see, is going down because I'm training more and more, and I'm getting worse. It's debatable, I think, why this is happening. Luckily for me, there have been some studies showing that possibly these are less trustworthy than we want, and that caution is suggested in using the current estimates of VO2max that are part of our system. So this is still an open problem. How do you go from cheap sensors into more refined measures, possibly that scale at that level? So I'm giving you this slide essentially as a hint of one of the things we are looking into because we have the data. Data is very important here. So it's not just accurately estimate VO2max, which is possibly something that is of interest of the wearable devices company. They're probably already looking into it. There are very few free living condition studies for this problem. We have the sensors, we have the tests, people being tested on the real machine. We can compare them, and so we can do them. Some of these wearables, certainly I imagine Apple is using GPS to estimate your speed to then use then the heart rate to go back to this VO2max value. There are ways in which perhaps we can get away without GPS and looking at this. The current epidemiological studies use questionnaires. How much have you moved this week? How many runs have you done? And that's the current precise state of the art that they use. So moving from that to wearable and then to cheaper sensor wearables for this sort of things is a very interesting thing. One thing we are doing, which is probably a bit more novel than what the current devices want to have, is can we forecast it? because we have data going 5 years, so from one data point here and then 5 years later, what can we say about a person's certain medical situation, demographic situation, going from this point into 5 years in the future? Can we say something about the fitness evolution, perhaps given some data points about their activity after 5 years? Can we put it all into a prediction framework? So this is kind of all about really accelerometer, cheap sensor going to higher level, how we do it and how we can make use of it. And before I go to the next part, which should be linked at the end, in fact, I want to give you, this I put in just because it's timely. This is a Lancet, which is a medical journal report published in January 2020, where they used Fitbit data of course, 2 years ago, of sleep and resting heart rate. Resting heart rate is a famously well-known measure to measure your level of somehow stress in your body. If your resting heart rate is higher, clearly you are your body is a bit more in overdrive. So they've proven that they could predict US areas in influenza, so flu take-up existence by using sleep and resting heart rate of people in the area. I wonder if this is applicable at today's epidemiological problems. And so I thought I should add it here. Another quite cheap sensor we have been using for a while is a microphone. The microphones are indeed embedded in most commodity devices and can be, however, quite expensive to use in terms of the data they generate, the processing they need, and the type of sampling that you need. So the continuous sensing can be indeed quite expensive. And this is work published in Ubicom in 2010. It was an on-device sensing framework for emotion recognition on a Symbian Nokia phone, which luckily for us had a very good battery. As you remember, probably most of you are too young to remember that phone. But that phone was amazing for this sort of research. If you didn't need other more advanced sensing, that definitely was. So we had a model based on Gaussian mixture models that was trained on actor voices of emotion. So actors were playing emotions, and they would, and we would train a machine learning model, and then would put that on device to recognize if the voice. So if my phone is here and I'm speaking, I would match the device would match my emotions based on this trained model. And that's what we were doing. We have since then developed it for Android, which much worse battery performance, of course, with respect to the super optimized Nokia brick phone. So this was, I think, quite far-sighted. 2010 was published, so the work was conducted a bit earlier, and it showed that emotion detection on the go, on device, was barely possible. Of course, our accuracy wasn't super good at the time. Since then, this is MIT Tech Review report from January 2017. Voice analysis could diagnose disease. So if you analyze voice from devices, and here is in the picture, their picture, there's an Amazon device, and sorry, this is not their picture. I can't remember if I put it here or if it's their picture, but in any way, the idea is that you could have signal of psychological stress, so PTSD was looked into. There are already a couple of technical papers on that, as well as heart disease, which is probably less intuitive to link to voice. But I've spoken to some cardiologists, and it seems that perhaps hoarseness of the voice, the interaction between the respiratory and voice apparatus and the areas around the throat that are cardiovascular has an influence on how this voice then comes out. And so there's this leading set of activities that start to use voice as a symptom of disease. And because, as I said, I don't need to cite my own papers, which I don't have in this particular area, I'm citing Shyam Golakota's paper on contactless cardiac arrest detection using voice. What they did here is that they took 991 calls, which in the UK are 999 calls, so emergency calls. They analyzed them with traditional machine learning, SVMs, and they looked for this it's called agonal breathing, which is a specific type of breathing that you do while you talk that is highly correlated with cardiac arrest disease. And they showed that you can go from this kind of voice detection immediately to detect, and they have quite a good accuracy in doing that. Of course, if you see from the title, they've gone further and they said, well, we use 911 calls, but actually it could be your device at home that could do the analysis and could do the diagnostics. So, so this is all about voice. But now I'm opening kind of, this is a 5-year project I've just started in using and looking at all the mobile and systems challenges and data challenges related to body sounds and how we can use them for diagnostics at various levels. So I'll give you a little bit of an introduction. I will stick to one particular let's say, clinical systems, like the cardiac system here, to describe it. So doctors listen to our heart. And by doing that, they use auscultation devices, like here at your left, or they use echocardiograms, which is essentially ultrasounds converted into images, and they analyze the images. This is quite an expensive procedure. That is a reasonably cheap procedure. Why use these techniques to detect heart conditions? Well, as I showed you, this phone already does one lead ECG by using the electrodes, and that's an ECG. And it can be done with much more leads and be more precise in the way it does, but it doesn't detect some of the specific cardiac diseases that could be detected. Here is an example that I've taken from, I think I took it from Wikipedia, in fact, that shows auscultation signals for abnormal heart sounds and various anomalies that you can have that are generated by different valve movements. So your heart has valves inside in the two cavities, and they can generate, so if they don't close well, or if they close too much, they can generate sounds that can be detected through auscultation or through ultrasounds. The ECG is unable to get those. The ultrasounds are very expensive techniques. So if you ever had an ultrasound, they actually stay on your body with this ultrasound tool for quite a while, and then they generate the images, and the images are analyzed. So they're very expensive. While auscultation, like with the stethoscopes, can be very cheap. However, there is no data. There's absolutely no data for it. So if you go to your doctors, they use normal stethoscopes, and they don't collect data. Ultrasound data is kept as much as X-rays, and all the medical imaging community has been working on looking at this data, especially recently, for a while. If you look at cardiac data, but also respiratory, they don't collect anything. I've asked a respiratory doctor who is in my college at Cambridge, I've asked her, how do you train your doctors? And the answer is, well, they follow me, and I make them listen to the same thing I listen, and then they learn. yeah. So there is no data for this, even if we wanted to perhaps scale up digital stethoscopes analysis to more automatic ways of doing it, both on wearables and on just getting the data and analyze. And this is Harvey. And because of what I said, Harvey is a simulation patient that emits different sound anomalies so that people can be trained. To find Harvey, the top medical hospital in Cambridge that specializes in cardiac and respiratory doesn't have a Harvey. They don't train doctor to auscultate anymore because you do an ECG, and if there is something wrong or someone says that they might have something wrong, you go and do a scan. There is no auscultation. Auscultation is a difficult thing for doctors to do. It's difficult to detect those murmur sounds. And so Harvey, from which we wanted to get some data, we had to go to Birmingham to get Harvey. So although I said that there is no data, some people are recently starting, this is a July 2019 paper, some people are starting to collect some data from digital stethoscope that can then be used to see if we can do something automatic on the data. This is 300 patients, and they used some traditional machine learning to detect murmurs, so this valve diseases, and cardiovascular diseases classification. They achieved a 92% accuracy already by looking at this data and knowing if this is possible. Now, when we started looking at this, we came up with, and here's the part where I discuss the problems in this domain. So even just asking the problem, can we diagnose X with sound from point Y, is a very difficult problem. Mostly because doctors know that they can somehow perhaps auscultate a valve murmur, or they know that some doctors can auscultate. They say, oh, the top consultants will be able to auscultate this properly. The junior doctors are not learning the skill, so they won't be able to do it so easily, interestingly. But also, when I asked, what if I had a microphone that was able to do, as good, but possibly even better than a human ear? What can I hear? Could I hear this disease? I said, I have no idea. And if I place it in this other place, could we hear something about this disease? I have no idea. So we are in uncharted territory where we don't know what this sensing can do. And we have absolutely we don't have data at all in this. And most importantly, probably for the mobile community, doctors don't stick to your belly the whole day. They don't listen continuously. There is actually not much literature, not much knowledge of what we can do for digestive diseases, for cardiovascular diseases. If we had something efficient that is attached to you for a while to understand if that something efficient was also smart enough to do some, intelligent analysis. So again, completely unknown situation. We tried for a while this is, because it's a keynote, I can do this. This is the first prototype. It's really bulky. It's a contact microphone that you put on your chest to put somewhere just to understand the issues with noise, the issues with continuous sensing, what we can do, where are the parameters for this. This was a year ago, was done as a master project. We have since then evolved, but I don't have a picture of anything newer in terms of devices and what kind of things we can integrate. So what I would like to do now is discuss the challenges and opportunity of this scalable sensing area that I can see, especially for audio, but actually related to other sensors that I described in the first part of my talk. So as I said, noise is a big issue. If you collect data from a digital stethoscope, that would, in a probably reasonably artificial environment, how do you go from there to the diagnostics in the wild through perhaps a more continuous sensor that is collecting the data continuously and perhaps doing analysis from that data. If you go back to the paper that I mentioned that was doing the analysis on the 911 calls, they tried to add some noise because they're trying to make the leap and saying, we have 911 calls data, we can do the analysis of cardiac arrest prediction, and we would like to do it from an Alexa. They try to artificially add noise to show that they could do it, because in an Alexa world, you are out there and there is noise. So there are some people that are trying to reach out in this direction, and it is a big problem, because whatever we do will probably be collected artificially initially, and then the next big issue is data labeling. Although we can get medical data saying this patient has heart murmur, the going into labeling the exact point in which the data shows the murmur is something that needs to be done manually if we go for traditional techniques, right? So how do we scale this up? Clearly, and the same is for any epidemiological studies that we're doing with MRC epidemiology there. This is a well-known problem in the Ubicom community, where we're trying to predict activity. Right? Activity recognition is also a difficult domain where labeling is missing. So techniques of transfer learning are starting to appear in the community, and I think they're very promising, and that's where all this is probably going for us. If you need scale for this, and we do need scale if we want this to really take the leap. I've talked about continuous sensing. One thing I haven't talked about is the elephant in the room, which is privacy. And luckily for us, I think this community has been looking at on-device modeling quite effectively. And in this specific area, this is definitely something that we could integrate. But there are challenges of doing this just because the models don't quite align. And I'll give a few examples in a minute. Personalization. The first time I put on the Apple Watch, it gave me a low heart rate scare. And then I Googled, and I found that I'm supposed to customize my low heart rate level by myself and not be scared by this. We should be able at this stage to push out this mobile sensing technology so that it auto-customizes. This shouldn't be happening at all. We're not there. And this is due to all these lacking pieces missing that needs to come together. I've been thinking in terms of development life cycle. So for this project, what we'll be doing is that we'll collect artificial data, and then we'll devise our models, and we'll build devices. But then, as I said, would this work in practice? Because there is noise. So we need noise-resistant model. We need the ability to personalize, because everyone will be different, and everyone will probably change. There is evidence that if you use biometric for authentication, for example, if you use activity for authentication, it changes over time. So if we start using these sounds or even acceleration for authentication, you might want to be able to adapt to the change of behavior. And the other elephant in the room is the battery. Can we have these models that are able to trade off the accuracy with the battery level that you have, and perhaps give you a different level of diagnostics just because at this point in time you have a certain battery level, you just exit your network analysis and give different results at that point. So I talked about incremental learning, and this is a project that was recently funded through Google, where we want to improve the modeling on continual learning. Continual learning, incremental learning, at the moment is mainly studied and can be mainly studied for traditional systems and can be very inefficient if you try to then coordinate your resources on a mobile device. So bringing those techniques that exist in theory, the formalizations of this technique to these devices is something very, very, well, new, I would say. And then considering where is it useful, especially for data that comes from our community. So mobile sensing community is something that we're interested in looking. So I'm giving you, I'm the keynote. I'm not giving you what I've done this year. I'm telling you what I will do next year, hopefully. And if you do that too, great. We'll do it together. That's absolutely fine. One thing that is really close to my heart, and I still have time for this, is reasoning on accuracy. And the more I look at the clinical, the more I realize that it's not all about accuracy, and we need to change the way in which we consider this. If you consider so atrial fibrillation is one of these arrhythmia-related diseases that can be detected through the ECG on your watch. And there was an article showing that it has high rate of false positive, which meant you would send lots of patients to doctors really scared, saying, look, I have this. And in reality, these things should have been not happening. In this sense, if you look at what the community is doing to really do clinical detection better, is that they're saying they are leveraging uncertainty. This is a paper that uses images to detect diabetic retinopathy, and it's a public data set. And they've used, of course, they use deep neural networks. But they've used Bayesian neural networks so that they could, instead of giving a point estimate, they would give a distribution. And a distribution, by using the distribution, you have a better estimate of uncertainty. The problems with this method, and that's great because it allows you to say, well, I have a certain accuracy, but look, this is my uncertainty. And then you can do all sorts of things when you have those two characteristics. The problems with these methods, they are very computationally expensive. Because they're working with distributions, and you need to calculate the means and the standard deviation and all that, and you need to run it quite a bit. And you need to go from this to something that perhaps we want to put on devices that are different. Not always. You might want to run this in the cloud, in which case perhaps this is already solved. But if you want to go to smaller devices, there are things that need to be done. And this is a paper of Tarek's group in Urbana-Champaign that was published in 2018, where they looked at how to move this deep neural network models for uncertainty to be very research savvy. And there are a few optimizations that they do. We're working in a similar area. We started just a year ago. If I remember correctly, they are working with they're working with fully connected neural networks, and so there's a lot more that this community needs to be done to make it interesting. I guess for my last 5 minutes, I want to move on one last thing, and then I'll move back to the findings and bring it all together. So we have talked about going from cheap sensors, analyze cheap sensors, getting the data, and trying to understand what are the limitations and the links of this to make it really scalable and to make it really a reality for these things to be usable. And I've given you a couple of, I hope, some points where this can be improved. At the same time, I've talked about watches, I've talked about phones, but there is another platform that is becoming perhaps the platform of study, and it could get clinical very easily. I've assisted to a talk of Romit Chaudhry, and he opens his talk by saying, this is the next smartphone. And I'm using is quote, it may be that this is the next smart monitor. It's a platform that has, or can have, a bunch of sensors, and we can add more sensors as a community. We can see what we can do on device. We can relate the device with other devices that we have, such as the phone and perhaps the watch, and do something really useful. This is a Mobicom 2019 best paper by Tom Wu's group, where they measure blood pressure with some clever techniques around the ear. It's not based on, oh, by the way, one thing I should have said is that if you're interested in this Earable things, we have a collaboration with Occupy Labs who have released this Earable platform, eSense, which is an open platform that you can work on and contribute, and it's open, unlike other Earables that we as an academic community can't work on. So I suggest you look at it if you're interested in innovating in this space. So Tam did this work. The only thing I would object here is to the word in the title, comfortable. I haven't met Tam since he published this paper. I don't think the particular current prototype is comfortable, but it definitely is an interesting direction to try to add cheap sensors that can do blood pressure monitoring is another holy grail in the epidemiological community. Hypertension is a big issue. It generates lots of money spent on so this is definitely a very interesting direction. We are particularly interested in transforming hearing impairment diagnostics and possibly support people with hearing impairments through devices that are not clinical grade. We're interested in that sort of gray area where people are still not clinical grade impaired, but maybe they need a little help, or they need help in diagnose the status they're on. We're already going around with these devices, and it should be easy to just go back and understand what can be done. This is our prototype studies. One of the things we're trying to understand is perhaps why all of these Earables don't have a magnetometer in it, which would help a lot with head attention, understanding. Your heading, understanding where you're looking at. There is a reason why there's no magnetometer. We are kind of doing a study of understanding why there isn't and what we can do without. I think now, to give you some time for a question, I have one more slide where I'll wrap this up. So I think we're in a phase where I would like to say mobile sense is on steroids. And the steroids are the little bit that we're adding as a community to make this reality happen and to scale the way in which medical studies and epidemiology can be done with these devices. It can be done at scale, but it also can be done continuously, which is something that they are often not used at having. And so they don't even know what they can do with it. We as a community don't even know what to do. The estimation, relying on not just accuracy, could lead to better clinical involvement. Having humans in the loop, to me, is essential here. And my take on this is that uncertainty is probably the path that leads to it, and finding ways to integrate that. We're in a great position as a community to solve the problems of privacy with on-device or on-the-edge learning and analysis. And so I think we can put our systems hat on and say to the world, well, we have a part of the answer as a community for you to privacy, which is we keep it close to the user. And we know how to do it. We know how to then trade off resources for it. And we can integrate whenever we want to use cheaper sensors because we want to scale more or because we can't do better. We can integrate some clever learning to compensate for that, to that loss of accuracy. And this will make it affordable and will make it usable. So I've given you a very positive view of where we're going. I don't think we're done at all here, although companies are still pushing up devices and apps that seem to have solved the problem. If you scrap through, there is a lot to do under that surface. I would like to thank my collaboration. This is mainly students that have been part of this project, and so I thought I should put them all up there. But I'm happy to take your question. I think we have some time. Thank you.